Hi, Terry QT with Deep Sea Foundation. I am talking to Dr. Minas Chrysopoulo from PRMA in San Antonio. Welcome, Dr. C.
Hello.
Hi.
Good to have you here.
Yeah, it's good to have you back and doing some videos. So I have some kind of general questions about post-deep, but also phase 2.
Okay.
Some questions came along. So you have phase 1. Then you have a grace period that you have to wait. I know, at least from mine, for insurance purposes for phase 2. Mm-hmm. We all kind of know about that. But let's say a patient wants to wait a little longer to have phase 2. They're just like maybe not ready for a number of reasons, mentally, support-wise, for whatever reason.
Vacation,
kids are not.
A wedding coming up.
Yeah.
Graduation.
I'm gonna get my hair fixed.
Yeah, all sorts of stuff. Yeah, there's no time. There's no time limit. So,
okay.
So it's minimum 3 months between the stages. If you're having more than one stage, which most people do.
Yes.
But if you want to delay it longer than that, it's absolutely fine.
Okay. Let's roll on to compression garments, because I get a lot of questions about, well, I didn't get compression garments.
It's 100% surgeon preference.
Okay.
I have several colleagues who don't use them ever. We use them all the time here.
Because?
We feel that a compression garment helps decrease with the swelling, and it also helps with patient comfort.
Well,
that's just our take.
So I came, you did my deep flap and you did my phase 2.
Mm-hmm.
I mean, from a patient standpoint,
mm-hmm.
I ask you the question, but from a patient standpoint, I got to tell you, even though I didn't maybe like wearing them, it was patient comfort.
Well, it's that they're not all created equal, are they? So
no.
So we use abdominal binders after the first stage, as you recall, and they're a bit of a pain because they ride up, and the ideal binder hasn't been invented yet, in my opinion.
Mm-hmm.
And then for the second phase, we use compression for, especially for areas that we've done liposuction.
Right.
So I get it. It's not the most comfortable thing, but
yeah.
Patients that don't need them or don't wear them, or their surgeons don't use them, they don't seem to do any worse. You know. So just because you didn't get one doesn't mean it's bad.
Right.
So that's 100% up to the surgeon. So just ask him or her.
Okay. So also post phase 1, I guess, a lot of women ask me about, and I think this is plastic surgeon specific too, talk to us about surveillance afterwards, because I know what you told me and I was very comfortable with it.
So there's no evidence-based consensus on this. Several years ago, it used to be that absolutely no one was getting any more surveillance after, say, a bilateral mastectomy, whether they had recon or not. The issue with autologous reconstruction, with tissue reconstruction, is that you can get areas of fat necrosis. Tissue turns hard. It can look different on a mammogram. You have a lesion now, a mass, a lump that you can feel in a reconstructed breast. And so there's been a push from some surgeons to continue regular screening afterwards, in essence, which a lot of patients, for a lot of them, that's a surprise, because some of them, that was actually part of the decision-making process to do the other side, for example, in ladies who had both breasts, who chose to do a contralateral prophylactic mastectomy.
Yes.
So again, it's very surgeon-dependent. In our practice, we leave it up to the breast surgeon to guide. So we recommend the patient, talk to their breast surgeon.
Okay.
If it's completely up to me, then I float the idea of a one-off study once all the reconstruction is done, all the stages, 6 months after the last stage, so things have settled, things are what they are. And a one-off study now provides a new baseline for comparison with other studies in the future. The reason I like that is because if something is found on that screening exam, you now can compare it if it becomes palpable later. So sometimes ladies lose weight and all of a sudden they feel something that actually was always there.
Yep.
And so knowing it was always there and seeing that it hasn't changed at all can be a source of putting their mind at ease.
That's what I had done.
Yeah.
And it does give me peace of mind, actually.
The counter argument, though, is it can also heighten anxiety.
Yes.
By having this baseline study done, and now it picks up something in a cancer patient that now people feel needs to be investigated, even if it's fat necrosis. And now we have to biopsy it. How can you not biopsy it? And this lady who had previous cancer, and so
then you go down the rabbit hole again.
So I appreciate that as well.
And I have to say too, from a patient standpoint, what I did when I went into my that MRI that day to the techs, I asked him, "Do you know about DIEP flap?" And I get the answer a lot. Nope, they didn't know. So I said, "Okay, look, here's what we're gonna look for. Possible fat necrosis. This is what DIEP is." They really appreciated it. Yeah. And so I think it helped them as they passed that information along to the reading radiologist.
Yeah, for sure.
And then, so you brought up a point a minute ago when you're about, telling the patients to talk to their breast surgeons. Since I was just at the breast surgeons meeting, interesting point. Is it kind of patient dependent upon where the tumor was, the location of it, closer to the chest wall, closer to the lymph nodes? Would then that precipitate telling the patient, talk to your breast surgeon, maybe it is a good idea, see what surveillance they want? Do you know what I'm asking?
Yeah, for sure. And I think all those points, I think that's a really important point. And I think that absolutely comes into the decision-making process, as does having nipple-sparing mastectomy,
yes.
Whether you've had a tissue reconstruction or an implant-based reconstruction. But to be honest, the opinions are quite varied. So for us, it doesn't even make sense to consider where her cancer was and this and that. We just say, speak to your breast surgeon.
Yeah.
It's just to make sure. I mean, they're the ones who really need to be making that final decision. I think it's only right that they're in charge of that decision making. For me,
team effort
has to be multidisciplinary. It's the only way to go.
I like that. Thank you very much.
You're welcome.